الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Malaria by Professor Mahmoud Hani Sulaiman. Infectious agent. Malaria caused by parasites of Plasmodium species. 4 species of Plasmodium infect humans. Vivax, oval, malaria, falciparum. Vivax, oval, malaria, and falciparum. Infection is most commonly by Vivax and falciparum. Most commonly Vivax and falciparum. The latter causing the most severe form of malaria. Falciparum cause the most severe form of malaria. Mixed infections may occur. Clinical features. The most prominent feature of malaria is fever. Classic descriptions of fever with regular recurring pattern. 2 to 3 days is not usually present when disease begins. Regular recurring pattern per 2 to 3 days. It is not usually present when disease begins. Irregular fever also may occur. Mixed infections, ineffective use of prophylactic drugs, and partial treatment. Irregular fever may also occur due to mixed infections, ineffective use of prophylactic drugs, and partial treatment. Patients commonly feel well on days when fever is absent. A presumptive diagnosis of malaria made for any person with high fever who went to a malarious area until proved otherwise. And this is we can use this in many cases when there is a epidemic or we are in endemic area. We can make presumptive diagnosis of the disease on some of the symptoms and signs present. Clinical continued. Early diagnosis with prompt treatment is essential. Why? Because malaria can be a fatal disease. If initial blood film is negative for malarial parasites, repeat in 24 hours, especially when temperature is rising. That is to say, there is a very obvious sign which can make us diagnose malaria. Repeat for the parasite. One negative test does not exclude diagnosis, especially if patient took antibiotics, which may lead to partial treatment of infection. Clinical. Rapidly rising temperature commonly lead to shaking, chills, muscle pains, back pain, nausea, and headache. And episode frequently ends with profuse sweating. Other symptoms may include confusion or other neurological signs, diarrhea, dark urine, jaundice, cough, and respiratory distress. This picture shows the pattern of fever. On the vertical axis is present the degrees, 35, 36, 37, and so on. This is the temperature, and here is the days, 1, 2, 3, 4. Here is the type of parasite, falciparum, which is the most severe, vivax, and malaria. As we see, increased 40, then increase between 1 day and the other. And here the rest period, the period with no fever for about 1 day or more. Here very short. Here more for 2 days with no fever. The fever mostly on 1 day. And here is the degree. It may exceed 40. It is at border of 40, and so on. Classic descriptions of fever is with regular recurring pattern per 2 to 3 days, is not usually present when disease begins. Irregular fever also may occur due to mixed infections, ineffective use of prophylactic drugs, and partial treatment. Severe complications of malaria: cerebral malaria, hypoglycemia, renal failure, and respiratory failure. Cerebral malaria characters equal coma, range of neurologic signs including generalized seizures, signs of increased intracranial pressure, confusion, progression to stable coma, may end with die. Hypoglycemia can present with metabolic acidosis and decreased blood pressure with hyperparasitemia. Also can be a consequence of quinine or quinidine-induced hyperinsulinemia. Renal failure due to acute tubular necrosis, rare in children less than 8 years. Respiratory failure without pulmonary edema. Respiratory failure without pulmonary edema. Continued severe complications: metabolic acidosis, severe anemia, vascular collapse, and shock. Metabolic acidosis due to lactic acidosis, hypovolemic function, and impaired renal function. Severe anemia due to high parasitemia, hemolysis, sequestration of infected erythrocytes to capillaries, and hemolysis of infected erythrocytes associated with hyperinsulinism. Vascular collapse and shock with hypothermia, adrenal insufficiency. People with asplenia who become infected may be at a risk of more severe illness and death. Syndromes primarily associated with vivax and oval infection are as follows: anemia, hypersplenism, relapse of infection, chronic asymptomatic parasitemia, nephrotic syndrome. Anemia, hypersplenism, relapse of infection, chronic asymptomatic parasitemia, and nephrotic syndrome. Anemia due to acute parasitemia. Hypersplenism with danger of splenic rupture, relapse of infection for as long as 5 days after primary infection due to latent hepatic stages, hypnozoids. Syndromes associated with Plasmodium malaria infection include chronic asymptomatic parasitemia, nephrotic syndrome. Here, severe Plasmodium vivax, malaria, Brazilian Amazon, and of 2-year-old fight with severe anemia. This is the little hand. When compared with the hand of the physician, you know that it is severe anemia. So the diagnostic features of severe malaria are cerebral malaria, respiratory distress, prostration, hyperparasitemia, severe anemia, hypoglycemia, jaundice, renal insufficiency, hemoglobinuria, shock, cessation of eating and drinking, repetitive vomiting, hyperpyrexia. Please print the table and use it. Here is the mechanism how these complications happen. First, cytoadherence, resetting, decrease RBC's deformability, lead to microvascular obstructions, which will lead to cerebral malaria. Hypovolemia, vomiting, diarrhea, fever. Hypovolemia due to vomiting, diarrhea, fever will lead to metabolic acidosis. RBC destruction, marrow suppression, nutrient deficiency, infections will lead to severe anemia. Pathogenesis of severe Plasmodium falciparum malaria. This is from severe Plasmodium falciparum malaria are commonly attributable to the effects of severe anemia, cerebral malaria, and sclerosis in young children. This schematic illustrates how multiple pathogenic events such as cytoadherence, destruction of uninfected lymphocytes, and production of inflammatory cytokines combine to produce the microvascular sequestration and metabolic acidosis that are central to the development of severe disease. The use of malaria prevention selected examples. Influenza endemic fever, classic dengue fever, acute schistosomiasis, Catayama fever, leptospirosis, African tick fever, East African trichomoniasis, yellow fever. This is the most important. Malaria can be diagnosed by demonstration of malaria parasites in blood film. Blood samples should be sent to a lab with experience in diagnosis of malaria by use of thick and thin films. Repeated exam may be necessary, as we said before, due to variations in density of parasites. Confirmation of species should be sought from a reference lab. These are the blood picture under microscope for different stages of Plasmodium malaria. Incubation period. Time between infectious mosquito bite and first detection of parasites in blood smear is around 2 weeks. Symptoms may not occur at the time, and first presentation of infection may be delayed for weeks or months. Commonly, clinical symptoms occur after 2 weeks for falciparum, 30 days for malaria, 2 weeks for vivax and ovarian. يبقى all about 2 weeks except for Plasmodium malaria. Suboptimal suppression with prophylactic drugs may delay clinical presentation, and transmission by blood transfusion usually with shorter incubation period if it is due to blood transfusion. Public health significance and occurrence. This is also important. Malaria situation worldwide is deteriorating. There are epidemics of transmission and areas that was previously eradicated. Drug resistance increase and the spread of vector resistance to insecticides. About 220 new infections per year occur worldwide. Disease is endemic in areas of Asia, Africa, Central and South America, considered one of three emerging diseases. is a summary of life cycle of malaria. First, sporozoite. Go to the liver, giving trophozoite, schizoid, merozoite, hypnozoite, infectious, and malaria. Which lead to trophozoite, merozoite, gametocyte, polycyst, and sporozoite. Now, details of the life cycle of malaria parasite. Here, please observe the pointer, red pointer. Here is exoerythrocytic cycle. Here is the erythrocytic cycle. Both are in humans. Here is sporogenic cycle. We'll begin cycle here in one. Mosquito takes a blood meal, injects sporozoites. Here it is taking, the mosquito is taking the blood meal. Goes to the liver cell. We will begin human liver stages. Infected liver cell 2, 3 schizont inside the liver cell, then ruptured schizont. The ruptured schizont goes to the 5 to begin human blood stages. 5. Here go to the RBCs, immature trophozoite ring stage, the so-called ring stage, mature trophozoite, schizont. Here is the schizont, ruptured schizont 6. Here is ruptured schizont. Then 7, infalciparum, gametocyte, either male gametocyte or female gametocyte. Here, this is in vivax oval Plasmodium malariae, either male or female. Then 8, mosquito takes a blood meal, ingests gametocyte. Then inside the sporogenic cycle, macrogametocyte, nine micro, either macro or micro gametocyte, then ookinete 10, then oocyst 11, then ruptured oocyst, and release sporozoites and injects it into the human again. This is a detailed. It will be explained in details in next slides. Malaria parasite life cycle involves 2 hosts. During blood meal, malaria infected female Anopheles species mosquito inoculates sporozoite in human host. 1. Sporozoites infect liver cells 2 and mature into schizons 3, which rupture and releases merozoites 4. Of note, in Plasmodium vivax and Plasmodium ovale dormant stage, hypnozoites can persist in liver and cause relapses by invading blood weeks or years later, because it is hypnozoites sleeping. After this initial replication in liver, exoerythrocytic schizogony, A. Parasites undergo asexual multiplication in erythrocytes, erythrocytic schizogony. B. These numbers and letters are found on the diagram I showed you. Monocytes infect red blood cells. 5. Ring stage trophozoites mature into schizons which rupture, releasing merozoites. 6. Malaria parasite life cycle continued. Some parasites differentiate into sexual erythrocytic stages, gametocytes. 7. Blood stage parasites are responsible for symptoms and signs. Blood stages responsible for symptoms and signs of the disease. Gametocytes, either male microgametocytes and female macrogametocytes, ingested by Anopheles mosquito during blood meal. 8. Parasite multiply in mosquito is known as sporogenic cycle. C. In mosquito's stomach, microgametes penetrate macrogametes, leading to zygotes. 9. Zygotes in turn become motile and elongated oocytes. 10. And invade mid-gut wall of mosquito, where they develop into oocysts. 11. Oocysts grow, rupture, and release sporocytes. 12. Which make their way to mosquitoes' salivary glands. Inoculation of sporocytes into new human host perpetuates the malaria life cycle. 1. Reservoir humans. Mode of transmission. A female Anopheles mosquito ingests gametocytes from an infected human. Parasites undergo in 8 to 35 days of development in mosquito before infective sporozoites form. Sporozoites transmitted to another person via bite of an infected mosquito. Disease may also be transmitted by blood transfusion or congenitally in untreated or inadequately treated cases. Period of communicability. Infected case may remain infectious for years if untreated or inadequately treated, so that gametocytes persist. Infected mosquito remains infective for its life. Susceptibility and resistance. People traveling to malarious area are at risk. Preventive measures. Travelers advise of 4 principles of malaria protection. Travelers advise of 4 principles. Be aware, avoid being bitten, chemoprophylaxis, immediately seek diagnosis. Be aware of risk, incubation period, and main symptoms. You must know them. Avoid being bitten by mosquitoes, especially between dusk and dawn. Take anti-malarial drugs, chemoprophylaxis, to suppress infection where appropriate. Chemoprophylaxis. Immediately seek diagnosis and treatment if a fever develops 1 week or more after entering malarious area. Immediately seek diagnosis. Personal protection against mosquito bites remains first line of defense against malaria. Measures to recommend include: avoid outdoor exposure, avoiding insect repellents, avoiding outdoor exposure between dusk and dawn, wearing long loose clothing after dusk, preferably in light colors, avoiding perfumes and cologne, using effective insect repellents, for example, products containing up to 20% DEET. 20% DEET. Prevention continued. Using knockdown sprays, mosquito coils, or plug-in vaporizing devices indoors. Using mosquito nets, especially pre-treated with insect repellent. There is no drug that is completely safe and completely effective for prophylaxis against malaria. The decision to recommend chemoprophylaxis and choice of drugs involve analysis of risks, benefits by following considerations: prevalence and type of resistance of malaria parasite to available drugs, level of malaria transmission in the area, duration and place of stay, especially in rural areas, intensity of vector mosquito contact, availability of health care, age, travelers' current health and medical history, risk of traveler not complying with recommendations. All prophylactic drugs should be taken with regularity for the correct duration, regularity and the duration of stay in malarious area, and continued 4 weeks after last exposure to infection. Continued for 4 weeks after last exposure to infection due to parasites may still emerge from river and lead to disease during this period. The single exception is atovacol or preguanil, which can be stopped 1 week after return. Prevention continued. Malaria poses a serious threat to pregnant women as it can compromise, possibly leading to premature labor or miscarriage. Pregnant women should be advised to avoid travel to malarious areas if possible. Similarly, malaria presents considerable risks for children, especially very young, and the choice of suitable drugs is limited. Mosquito avoidance measures should be emphasized. There is no vaccine available. Prevention continued. Survey for malaria transmission. Objectives is to estimate magnitude of the problem, planning for prevention and control. Not only determination of magnitude of the problem, but also planning for prevention and control. Procedures: work plan, personnel, instruments, transportation, time, map of area with hydrography, canals, pools, trains, and others. Breeding places. Their distance from houses is determined to find if they are within the flight range or not. Enumerate population. Decide whether all population or probability sample of for case finding. Calculate prevalence of disease. To be continued. Study of human infection by malaria-metric indices. Parasitic index, gametocytic index, splenic index. Parasitic index, percent of positive blood films in children less than 10 years. Gametocytic index, percent of gametocytes in blood films equal infectivity to mosquitoes. Nota bene, any other stage equal disease. Any other stage but gametocytes equal disease. Splenic index, percent of splenomegaly among persons examined, but value less in each due to the infection. Study of malaria infection in mosquitoes by oocyst index, percent of mosquitoes with oocyst equal infected mosquitoes. Sporozoite index, percent of female anopheles with sporozoites in their salivary gland equal infectivity of mosquitoes. 3. Mosquitoes index, number of female anopheles per room during day. Study of types of anopheles. Pharomesis in rice fields. It is found in Egypt all over the country. Carry benign tertiary malaria. Bites at night. Prefer animal blood. Zooprophylaxis. Sergenti in oasis and transmit quartan malaria. Multicolor, no rule in malaria transmission. Gambia invader from Sudan. If it is present, it is a dangerous situation. Most dangerous vector due to high efficacy, due to easily provided breeding places, bites per day and night, indoor and outdoor inhabitant, and under all conditions prefer human blood, transmit malignant malaria. Then conduct a mass campaign for treatment and prevention after doing this survey. Prevention continued. Environmental sanitation, e.g. filling and draining of shallow water, larvae size and biological larvivorous fish, Gambosia fish, Prevention continued for man. Blood donation. History of malaria infected from tropical Africa, Greece, Romania. Plasmodium malaria may remain infectious for years. Visitors to other areas may donate blood after 3 years. From chemoprophylaxis cessation, returning from endemic areas without taking any drugs may donate blood after 6 months. Prompt and effective treatment. Chemoprophylaxis for those going to endemic areas. Look after. Finding notification to the health authority. Isolation under the screen till blood is negative. Compare disinfection, non-immunization, no vaccine till now. Investigation for contacts and source of infection, history of previous infection, of exposure, needed sharing, investigate and treatment of all shared the equipment. Blood transfusion infection, locate all donors, examine their blood for malaria parasite and for malaria antibodies, parasite positive donors treatment. International measures. This is also the prevention. Disinfectation of aircraft before departure or in transit using a space spray insecticide. Disinfectation of aircraft and ships and other vehicles on arrivals from endemic areas if authority suspect importation of malaria vector. Anti-mosquito measures within flight range or ports. Anti-malarial drugs to potential infected persons. Control of case. Isolation of case is not required. Mosquito contact with patient prevented, especially in tropical areas where mosquitoes capable to transmit disease are present. Treatment is complex and advice taken from infectious disease physician. Most strains of Plasmodium falciparum today are resistant to chloroquine. Only Plasmodium falciparum contracted in some parts of China, Central America, and Middle East are still sensitive to chloroquine. Vivax and Oval and Malaria are sensitive to chloroquine, but Vivax resistant to chloroquine found in Irian Jaya, Myanmar, Papua New Guinea, and Vanuatu. If species cannot be identified, patient treated as for most serious infection with falciparum. Although Primaquine reduces the risk of relapse of disease, relapses can occur. Treatment continued for falciparum and Vivax, 7 days of quinine sulfate, followed by 500 milligram 12 hours later. Other malaria, chloroquine phosphate. So quinine sulfate or chloroquine phosphate. These drugs used to treat malaria as recommended by U.S. Center for Disease Control and Prevention, CDC. Studied preventive and used details of the treatment. Please print it and use it. This map shows the malaria endemic countries, both in Americas at bottom and in Africa, Middle East, Asia, and South Pacific on the top. The countries in red are those chloroquine sensitive, and the countries in green are those chloroquine resistant. Control of stopping compliance policies of any blood transfusion from this should be warned that they may also be at risk for developing disease and should seek help promptly if suggestive symptoms develop. Outbreak measures in outbreaks of malaria require immediate public health interventions. Vaccination, it is under trials. Volunteers immunized under chloroquine prophylaxis will leave Plasmodium falciparum sporozoites found to develop long-lasting pre-erythrocytic immunity. ISS is a vaccine based on protein component from cells of the falciparum sporozoites proved safe, well-tolerated, and immunogenic in initial clinical trials. During an initial 12-month follow-up period in Infectious trials, RTS vaccine conferred about 50 to 30% protection against falciparum malaria in African children aged around 17 months and 6 to 12 weeks respectively. 15 around 17 months, 50 around 16 months, 30 around 12 weeks. Over a 4-year follow-up, however, ISS vaccine from 44 to only 0.4 in African children ages around 17 months. In July 2015, European regulators found risk-benefit profiles of RTSS per AS01 mosquitoes to be favorable from a regulatory perspective for use as oral vaccine. Some recent publications review important concepts in malaria vaccinology, discuss state of research in the field. Progress was made with vaccine candidates as Duffy binding protein of Plasmodium vivax, a PFEMP1 molecule involved in falciparum malaria of pregnancy, live or radiation attenuated Plasmodium falciparum sporozoites, and molecules critical to the invasion of erythrocytes by Plasmodium falciparum merozoites. That is to say, it is still under trial. وفي النهاية أقول الحمد لله رب العالمين و thank you for your good listening.